My lecture today is about the interstitial lung disease and the disease of the pleura and the chest wall. As the lung and the pleura and the chest wall, they act together to perform the main function of the respiratory system, which is the ventilation and the gas exchange. So any disease which affecting the lung, the pleura and the chest wall, this will interfere with this function. They making a problem in the gas exchange. So I discuss each disease separately. The learning objective to be able to describe the interstitium, the definition of the interstitial lung disease, the classification, etiology, representation, and diagnostic evaluation. What is the interstitium? The interstitial space is defined as continuum of loose connective tissue between alveoli throughout the lung. Here is the diagram which shows us this is the interstitial space or interstitium, which is lined between the alveolus and the capillary. The alveoli are lined with the one layer of the epithelial cell, and this contains two types of the pneumocyte. Type 1 pneumocyte, which facing the endothelial cell, and the type 2 pneumocyte, which secreting the surfactant, this which prevents the collapse of the alveolus. And here is the capillary, which is lined by single layer of the endothelium. Between them is the interstitium, which contains a connective tissue which form of the elastin fiber, collagen fiber, and other cell. Here is the histological aspect of interstitium. Here is the alveolus, here is the capillary. This is the alveolar epithelium, and this is the capillary endothelium. Between them is the interstitium. It is labeled as Z zone. So does the interstitial disease affect just the interstitium? So the answer is no. Why? Because the interstitial lung disease represents a large number of conditions that involve the parenchyma of the lung. It means involving the alveoli, the alveolar epithelium, the capillary endothelium, and the space between these two structures, as well as involving the perivascular and the lymphatic tissue. So the structures which are affected, as I mentioned, acini, which is composed of the respiratory bronchiole and the alveoli, alveolar lumen, alveolar membrane, bronchiolar lumen, and the bronchioles. And the cell which involved are epithelial cell, endothelial cell, mesenchymal, macrophage, and some inflammatory cell. We come to the interstitial lung disease, or it's called also diffuse parenchymal lung disease, or sometimes called pulmonary fibrosis. Interstitial lung disease is not a specific condition, but it is a heterogeneous group of conditions associated with diffuse thickening of the alveolar wall with inflammatory cell and oxidate. And the net result are fibrosis of the alveolar wall and scarring of the alveolar wall. This is a group of disease caused by a variety of the causes which have similar pathophysiological effect and clinical feature. This is the classification of the interstitial lung disease. There is no one classification. And the classification for interstitial lung disease is different. It depends sometimes on the historical procedure, or sometimes depends on the clinical presentation. This is the most simplest classification. So the classification of interstitial lung disease we classify according to the causes. First, occupation. And those patients who work in some occupation develop the interstitial lung disease, like asbestosis, silicosis, colorectal pneumoconiosis, and others. And those who receive treatment for many diseases, like radiation. Those who received radiotherapy for malignant disease and for other diseases, they develop radiation pneumonitis. Or there are many drugs which can cause pulmonary fibrosis. The most important of these drugs are methotrexate, nitrofurantoin, amiodarone, and other chemotherapeutic agents like busulfan. Or there are a group of diseases called connective tissue disease or collagen vascular disease. This mainly affecting the joint. It is multisystemic disease, mainly affecting the joint, but also can causing pulmonary fibrosis. The commonest one is rheumatoid arthritis. The other could be SLE, systemic lupus erythematosus, polymyositis, scleroderma, and Sjögren syndrome. Immunological causes, mainly you have sarcoidosis and hypersensitivity pneumonitis. And idiopathic, which form the most important and the wide, the biggest number of cases, which is mainly idiopathic pulmonary fibrosis, IPF, idiopathic pulmonary fibrosis. There is other type like usually interstitial pneumonitis or non-specific pneumonitis or other causes. There are many, but the commonest one it is idiopathic pulmonary fibrosis. Here it is the incidence or distribution of the interstitial lung disease. As the commonest one, it is the pulmonary fibrosis, idiopathic pulmonary fibrosis. After that came the occupational disease, the connective tissue disease, others causes also like the Langerhans, so we come with the distribution of the interstitial lung disease. I see the commonest one is pulmonary fibrosis, idiopathic pulmonary fibrosis. The other could be occupational like asbestosis, chemicals. Here, the sarcoidosis in our country is not common. In Europe country, it is more common, especially in the North Europe. But in our country, the incidence it is less than 1%. Pathologically, the interstitial lung disease have equally the same pathology, which is combination of the intra-alveolar inflammation with the cellular infiltration, and these immune cells and their cytokine injure the epithelial cell and endothelial cell, and the net result in the alveolar and interstitial fibrosis with alteration of the alveolar architecture. So the main pathology it is intra-alveolar inflammation with cellular infiltration and the fibrosis of the alveolar and interstitial wall. The pathophysiology of the interstitial lung disease. The development of the fibrous tissue in the interstitium make lung less compliant and tending to produce the restrictive pattern or restrictive ventilatory defect. Why? Because the alveolar wall is fibrosed and become more stiff, and there is also fibrosis in the interstitium, so the lung or the alveoli, the lungs will become less compliant, so it produces the restrictive ventilatory defect. Here, airway resistance is not increased, not like in airway disease like COPD and asthma. The airway resistance is not increased. So the FEV1 over forced expansion volume per 1 second over forced vital capacity ratio, this can be normal or more than 80%. So the lengthening of the diffusion pathway between the alveolar air and the blood, this impairs the gas exchange, mainly affecting the oxygen uptake. So the oxygen reaching the capillary, reaching the blood with difficulty and result in the hypoxia and normocapnia. Why? Because the distance to the diffusion of the oxygen is much greater than that of the CO2. So the net result would be hypoxia. There may be normocapnia or hypocapnia. This is the restrictive ventilatory defect. We come to the clinical feature of the interstitial disease. These features are common to the all interstitial disease, but also sometimes each disease may have some other symptoms. But these features are common to the all interstitial disease. The clinical presentation for the symptoms. The main symptoms are dry cough, persistent and decreasing cough, not associated with the sputum. And there is breathlessness, shortness of breath, which is usually progressive exertional dyspnea and of insidious onset. The patient may have fatigue, may have weight loss, but the main specific symptoms are dry cough with progressive exertional dyspnea. By physical examination, there is typically bilateral and basal crackles or crepitation. In some cases, there is clumping of finger, which is common in idiopathic pulmonary fibrosis and also seen in the asbestosis. Central cyanosis, tachycardia, tachypnea, and sign of the right side heart failure, it appear in the advanced disease. Radiological find also, it is common to the interstitial disease by the chest X-ray and by the high-resolution CT scan. By the chest X-ray may be normal in the early or limited disease, but later on, typically, the change will be small lung volume with the reticulonodular shadowing. The reticular shadowing, which appear as the lines, multiple lines in the lung field, or nodulars, which appear as multiple dots, or combination of both called reticulonodular shadowing in the chest X-ray. But this is still not diagnostic. By high resolution CT scan, HRCT, there is combination of, there is a ground glass appearance in the both lung, or reticulonodular shadowing, or later on may drop honeycomb cyst, and it's like خلايا النحل, or the rat result develop traction bronchiectasis. This depends on the stage of the disease. We come to the chest. Here the chest X-ray, there is the some in both sides. This are linear shadows, and this is the nodular shadows. This is called reticulonodular appearance in the X-ray. By this scan, it is more clear. You see, this is the nodule, multiple nodule here, usually present in the base or in the periphery also. And last one, there is honeycomb appearance. This is the honeycomb appearance, and this is the ground glass appearance. So this is typical of the interstitial lung disease. We come to the pulmonary function test. As said, the pulmonary function test is that of the restrictive ventilatory defect. The forced expiratory volume per 1 second decreased or normal, but mainly the forced vital capacity is decreased. So the ratio is either normal or increased. It is either 80% or more than 80%. There is reduction in the lung volumes and capacities. So vital capacity and total lung capacity are reduced. There is impairment of the gas transfer, and there is the reduction in the diffusion lung capacity for the CO. And exercise test assess the exercise tolerance and exercise related for in the SA2. And if the patient do exercise, this result in the reduction of the saturated oxygen. So the pulmonary function is mainly this restrictive ventilator effect, plus reduction in the lung volume, plus impairment of the gas transfer. The blood gas analysis isolate is mainly hypoxia. Later on, the patient may develop hypocapnia, or it pass to the type 1 respiratory failure. So the hallmark of the interstitial lung disease, there is a progressive dyspnea and dry cough. There is restrictive physiology on pulmonary function test. Yeah, pulmonary function test show restrictive defect, and the chest radiograph or thoracic CT scan show diffuse reticulonodular infiltrate or ground glass opacities. So here I finish the common feature and radiologic appearance and the prognostic test of the all interstitial disease. Now I come to the specific disease. As I mentioned, the idiopathic pulmonary fibrosis is the commonest type of the interstitial lung disease. This is a progressive inflammatory condition of the lung, and the cause is unknown. It is of insidious onset. Pathologically, it is a combination of the alveolar inflammation with the cellular infiltration, mainly are macrophage, eosinophil, and neutrophil, plus the fibrosis and scarring of the alveolar wall and interstitium, like the pathology of other interstitial disease. By lung biopsy, UIP, or called usual interstitial pneumonitis, is the histological pattern predominantly encountered in the IPF, idiopathic pulmonary fibrosis. In the early stage of this process, this can be restrained or stopped by treatment with steroid. But later on, when the fibrosis develop, the steroids are less effective. The clinical feature of idiopathic pulmonary fibrosis. The condition is relatively rare, 3 to 5 per 1,000. And the male is twice affected more than female. The age usually between 50 to 70, and mostly affecting the middle age and elderly patient also. And patient report progressive shortness of breath on exertion, and exertion dyspnea, with a non-productive cough. Clubbing of finger is seen in most of the patient. And by auscultation, there is bilateral inspiratory fine crackles, which can be detected mainly on the listening to the chest. So by listening to the chest, there is mainly bilateral fine cracking. We come to the diagnosis of the idiopathic pulmonary fibrosis. Diagnosis usually is clinical. The patient is elderly patient, has insidious onset of the progressive exertional dyspnea and dry cough, and by auscultation there is bilateral basic repetition. The clubbing of finger is common in such patient, but the diagnosis mainly here is confirmed by the CT scan. Chest X-ray may be normal, or there may be reticular endothelial, but the CT scan show area of the ground glass appearance and reticular nodular shadowing, which mainly prominently seen in the lower zone. So the prominent appearance of chest X-ray is in the lower zone. A bronchoscopy is seldom necessary unless there is a significant possibility of infection or malignant disease. And we are not sure about the diagnosis. We can do bronchoscopy with the patient and also do bronchoalveolar lavage, and at the same time we can do transbronchial biopsy. Lung biopsy should be considered in case of diagnostic uncertainty, when still a diagnosis are not certain by the clinical feature and by the CT scan. At that time, the lung biopsy may be done. The prognosis is poor. 3 to 8 survival is very low, less than 50%. Here I speak some point about the management, because this disease is a progressive disease, and usually the treatment is difficult. But usually we start with the combination of prednisolone, corticosteroid, azathioprine or immunosuppressive drug, and N-acetylcysteine. This has shown some effect, but usually it is not improving the prognosis. The corticosteroid should be given in high dose prednisolone. immunosuppressants like azathioprine and methotrexate. And now there is a new drug, this drug which can help to stop the fibrosis or reduce the fibrosis, called antifibrotic medication. Mainly use the pirfenidone and 90-danib. But the best treatment and the only treatment which show to prolong the survival in advanced IPF is the lung transplantation. We come to the other disease which is called pneumoconiosis. What is the pneumoconiosis? Prolonged exposure to the inorganic dust, prolonged exposure for years to the inorganic dust lead to the diffuse pulmonary fibrosis. This is called pneumoconiosis. So pneumoconiosis is the diffuse pulmonary fibrosis due to the prolonged exposure to the inorganic dust. The pathological result depends largely on the inflammatory and fibrotic response to the particular dust. The fibrogenic properties of the mineral dust vary, silica being the markedly fibrogenic, whereas the iron and the tin are almost inert. So the most important type of the pneumoconiosis are coal-worker pneumoconiosis, asbestosis, and silicosis. We come to the asbestosis. Asbestosis, so it is pulmonary fibrosis occurred due to the inhalation of the asbestos fiber, and this lead to the not only to the pulmonary fibrosis, lead to the number of the condition which often develop after long exposure to the asbestos dust. There are some occupations which are at risk of developing asbestosis, and I mentioned it. Those occupations like boiler and pipe laggers, railway engineering workers, some construction industry workers, and those who are working directly with the mining and the processing of the material. As I mentioned, asbestos inhalation is associated with the many diseases, not only the pulmonary fibrosis. The commonest benign pleural plaques, it may result in the pleural effusion, it result in the asbestos or pulmonary fibrosis, and also result in the mesothelioma, which is a primary malignancy of the pleura. And also there is an increased incidence of lung cancer to develop in those patients who are exposed to the asbestos. And this is the diagram. Sorry. We come to the other subject or other disease of the interstitial lung disease, which is called radiation pneumonitis. Targeting radiotherapy to the certain tumor or malignancy is inevitably accompanied by radiation of the normal lung tissue, and this results in the radiation pneumonitis. And there is two types of radiation pneumonitis: acute and chronic. Acute radiation pneumonitis, which is typically seen within 6 to 12 weeks after radiation to the tumor or patient receiving radiotherapy, and this is present also with cough and dyspnea. This may resolve spontaneously when we stop the radiation, or sometimes respond to the corticosteroid treatment. The chronic interstitial fibrosis or chronic interstitial pneumonitis, this may present several months after the radiation, and also present with the exhalation, dyspnea, and cough. And the established post-irradiation fibrosis does not usually respond to the corticosteroid treatment. The drug-induced interstitial lung disease. As I mentioned, there are many drugs which can cause lung fibrosis, and this pulmonary fibrosis occur in response to a variety of drugs, but seen most frequently with this drug: methotrexate, bleomycin, amiodarone, and difrantoin. methotrexate, which is used for treatment of the leukemia, some malignancy, rheumatoid arthritis. Bleomycin is also used for the treatment of the malignancy. Amiodarone is anti-arrhythmic drug used for treatment of arrhythmia, and nitrofurantoin, which is urinary antiseptic. The pathogenesis may be an immune reaction, similar to that in the hypersensitivity pneumonitis, which specifically attract large number of the eosinophil into the lung. Then I pass to the other large group of disease called connective tissue disease. And this connective disease is a multi-systemic disease affecting most of the system, mainly affecting the joint, result in the arthritis, polyarthritis, can affecting the lung, the skin, can affecting the brain, the blood also, and also affecting the lung. Sometimes pulmonary manifestation may come before the arthritic manifestation. And the commonest one of them is rheumatoid arthritis. But there is other disease like dermatomyositis, polymyositis, Sjogren syndrome, systemic lupus erythematosus, and scleroderma. And this, as I mentioned, it affecting the lung. It can causing diffuse pulmonary fibrosis, or sometimes can causing pleural or other. We come to the rheumatoid lung disease. I may predate the arthritic symptoms. Yani the symptom of the lung disease may become before the arthritis. It caused by disease itself or treatment, because many anti-rheumatic drugs like methotrexate or other drugs can causing the lung fibrosis, affecting male more than female. And the treatment is that of rheumatoid arthritis, and by giving the drug for rheumatoid arthritis, usually with steroid here or sometimes observation. And the progress depends on the type affected. Either this diffuse fibrosis or perfusion or other. Here is the pulmonary complication of rheumatoid arthritis. The commonest one is causing diffuse pulmonary fibrosis, which are mainly affecting the base of the lung, or can causing rheumatoid nodule, the benign condition. Sarcoidosis is a clinically well-defined systemic granular disease of unknown etiology. This is a condition which affects many systems of the body, mostly commonly affecting the lung, the skin, eyes, and the lymph node. The characteristic feature is the presence of the non-caseating granulomata. It is more often described in the cold part of the Northern Europe. The basic pathogens include pulmonary inflammation, formation of non-caseating granulomata, and then interstitial fibrosis. Sarcoidosis is often asymptomatic. Usually when the patient do chest X-ray, there is bilateral lymphadenopathy. There is genetic predisposition. Some families are affected more than others, and sarcoidosis occur less frequently in the smokers. Cough and breathlessness are the main feature. The patient also may develop extrapulmonary feature. Chest X-ray may be normal, or the patient may show some changes. There are 3 stages of the sarcoidosis in the chest X-ray. Stage 1, there is bilateral hydrolymphadenopathy. Stage 2, there is pulmonary infiltrate with or without bilateral hydrolymphadenopathy. Stage 3, there is pulmonary fibrosis. And this should be differentiated from the lymphoma and TB, and the treatment either observation or sometimes we give steroid. The other disease is hypersensitivity pneumonitis, or called extrinsic allergic alveolitis. This is a term. It includes a wide number of conditions in which the inhalation of the organic material trigger diffuse allergic reaction in the wall of the alveoli and the terminal bronchiole. And when the patient are exposed to the organic material, after that he may develop allergic reaction in the wall of the alveoli and terminal bronchiole. And this may be either acute or chronic. Acute form, also one example of the acute form is a farmer's lung. Farmer's lung, which occurred due to the exposure to the antigen, which derived from the thermophilic actinomycete, which is found in the maldehyde, يعني التب المتعفن, which produce first an influenza-like illness 4 to 9 hours after exposure. And the patient may develop fever, malaise, myalgia, nasal discharge, sneezing, and later on patient develop dry cough and breathlessness, which sometimes may be very severe. By examination of the chest, there is fine mid and late respiratory crepitation. There is fine crepitation in both lungs. Sometimes also we may hear wheezes. The chest X-ray show diffuse micronodular infiltrate, which are denser toward the hilum. The chronic form, example of chronic form, it is a Bert fancier lung. Here there is long-term exposure because it is chronic, to the antigen derived from the pigeon or from the Bodgerigars, which called this babaga. And this lead to insidious onset of malaise, dry cough, shortness of breath over months or years. By auscultation of the lung, there is respiratory crepitation in both lungs, and chest X-ray may be normal or may show pulmonary fibrosis affecting the upper zone. So here I finish the interstitial lung disease, then I pass to the other disease, which is the pleural disease. This diagram shows the lung which is covered by the visceral pleura and the chest wall, and the other parietal pleura covering the chest wall interiorly. So this parietal pleura and this visceral pleura, between them is the pleural space, which containing the serous fluid. Normally, the pleural space is a potential space between the two layers of the pleura and contain 3 to 8 ml of the clear fluid, low protein content, and small number of the mononuclear cell. What is the function of the pleura? The function of the pleura is, in health, is to allow the movement of the lung against the chest wall with the breathing. Both layers of the pleura are covered with a common film of fluid which is produced from the parietal surface, and this absorbed by the parietal lymphatic vessel. The parietal pleura is well endowed with the pain fibers from the intercostal or phrenic nerve. So in the parietal pleura is involved by the infection or by it can causing pain called pleuritic chest pain. There are many diseases of the pleura. The commonest one is the pleural effusion. There may be empyema also, and there may be pleural malignancy. There is also pleurisy, which is the dry pleurisy, which is the inflammation of the pleura, and the patient can present with a typical pleuritic chest pain. And this inflammation can be caused either primarily by infection by either viral infection or bacterial infection, or secondary, which is caused due to the pneumonia or consolidation which invading the pleura, or from malignancy also. The pleural effusion is the commonest disease affecting the pleura if there is accumulation of the serous fluid within the pleural space. The hemothorax, it means the presence of the frank blood in the pleural space. Chylothorax is the presence of the chyle in pleural space, which is milky in appearance and contain high triglyceride level. Empyema, this frank pass in the pleural space and usually occur, this bacteria usually occur after parapneumonic effusion. We come to the pathogenesis of the pleural fluid accumulation. Some conditions can cause an increase in production and some can cause decreased absorption of the pleural fluid. So when there is increased production and decreased absorption, there is fluid accumulation in the pleural space. The cause of increased production are increased hydrostatic pressure, decreased oncotic pressure, and lastly, increased permeability of the capillaries. Decrease of obstruction occurs to the lymphatic blockage, thoracic duct disruption, and elevated systemic venous pressure. There are two types of the pleural effusion called transudate and exudate. Transudate, it means it have low protein content, less than 30 grams per liter, and means there is an increase in the hydrostatic pressure or decrease oncotic pressure. The exudate contain high protein content, more than 30 grams per liter, and mainly it is due to the increased vascular permeability. And it means there is infiltration of pleura by the infection, inflammation, and malignancy. How can we say that this exudate or transudate? We have Lyons criteria, which contain 3 criteria. Any of these criteria, if present, it is exudate. The first criteria are pleural fluid protein to the serum protein ratio more than 0.05%. A pleural fluid LDH to the serum LDH more than 0.06. Or pleural fluid LDH more than 2/3 of the upper limit for the serum LDH. So any one of these criteria if present, this is exudate. Why we divide the fluid to the exudate or transudate? Because each has its causes. We come to the cause of the exudative pleural effusion. Either infection, with the commonest either pneumonia called parapneumonic effusion or tuberculosis effusion, or may occur after pulmonary infarction or malignant disease. So any malignancy which invading and infiltrating the pleura, like bronchogenic carcinoma, CI larynx, CI stomach, and CI pancreas can causing malignant pleural effusion also. The other is the subdiaphragmatic disorder, and there are some disorder below diaphragm, like subarachnoid abscess, liver abscess, pancreatitis. All these can cause reactionary pleural effusion. And the other is inflammatory condition, connective tissue disease. As I mentioned, like SLE, rheumatoid arthritis, and other also can causing exudative pleural effusion. These are the common cause of the exudative pleural effusion. There are other rare causes, I don't mention it. I come to the transudative pleural effusion. Here, mainly, it's caused by this following. These rare causes. There's either congestive heart failure or hypoalbuminemia, which occur in the nephrotic syndrome or liver cirrhosis, or patient with a renal failure. These are the main cause of transudative pleural effusion. The clinical feature of patient with a pleural effusion, he may present with a pleuritic chest pain because there is inflammation of pleura, so we present with a pleuritic chest pain and irritative dry cough. Later on, when there is accumulation of the fluid, patient may develop shortness of breath or dyspnea. The patient may have feature of other disease like fever, rigor, sweating, weight loss. This due to the causative. These are features of causative agent of the cause of pleural effusion. The signs of pleural effusion include: first, there is decreased expansion of the affected site. By percussion, there is tony dullness. There is decreased vesicular breathing, and also by auscultation and decreased vocal resonance. And when the effusion is massive, the mediastinum is shifted to the opposite side. The trachea and the apex beat is shifted to the opposite side. The chest X-ray, The chest X-ray finding usually here this is the normal side, and this is the side of pleural effusion. Here this is the costophrenic angle. This is the costal margin, and this is the costophrenic angle. Here it present is normal, but here it is absent. Why? Because there is accumulation fluid, and as the fluid accumulates, it appears as the homogeneous opacity with the sign rising laterally to the axilla. This is called meniscus sign. And when the effusion becomes more massive, can causing mediastinal displacement to the opposite side. Empyema it means, and usually it is oxidative pleural effusion caused by direct infection, usually by bacteria of the pleura, and there is a frank pus in the pleural space. Microscopically, there is neutrophilic leukocytosis which are present in the large number in the pleural fluid. A pleural fluid pH becomes decreased less than 7.2, and empyema it is loculated or insisted empyema. Sometimes it may be difficult to be aspirated by needle aspiration, so it needs the chest tube for aspiration, and it is almost invariably is unilateral. Actually, the main cause is either bacteria, and usually pneumonia or lung abscess, or can cause after tuberculosis. The clinical feature are the same as pleural effusion, but here there is pus collection. So the pus collection can causing pyrexia, which is usually high and intermittent pyrexia, and fever. There is rigor, sweating, malaise, and weight loss. And by complete picture, there is the polymorphic leukocytosis, and C-reactive protein is high. By examination, it is a feature of the pleural effusion, and there is decreased expansion, decreased focal erythemas, there is stony dullness, and there is decreased air entry. Empyema should be suspected in any patient with pulmonary infection if there is persistence or recurrence of the pyrexia despite the administration of the suitable antibiotic. The treatment usually here, if it's due to the bacterial infection, so the most important treatment is the drainage. So this pus should be drained either by the chest tube drainage or by the surgical descomplication, and also we give him the proper antibiotic. And this is the CT scan. This empyema, which is present here, this localized cystis, this also is empyema here, this empyema here, and this is the ultrasound. There is loculated empyema here also. We come to the pleural fibrosis or pleural thickening. Fibrosis of the pleura may develop as a result of the unabsorbed pleural effusion. And a patient with a pleural effusion which was not aspirated or not absorbed, this results in the thickening of the pleura and fibrosis. A small degree of the pleural thickening may don't give any effect and not causing symptom. But widespread fibrosis restricts the expansion of the lung, and with a measurable reduction in the lung volume and compliance, but with normal gas transfers measurement. And clinically it appears as pleural effusion, but when you aspirate there is no fluid. We come to the other disease of pleura, which is the malignancy of the pleura. There are benign tumor, but the commonest is malignant tumor. The commonest is secondary or metastatic malignancy of the pleura, which is malignancy from anywhere, commonly from the lung, bronchogenic carcinoma, or CA thyroid, CA of the stomach, CA of the pancreas, may metastasize to the pleura and causing malignant pleural effusion. Or could be primary, which is mesothelioma. It's a very rare disease, mainly occur in those who are exposed to the asbestos dust. Come to the mesothelioma. This is a rare neoplasm, primary neoplasm of the pleura, which commonly arise from the mesothelial surface of the pleural cavity. Practically all victims have been exposed to asbestos 20 to 4 years before. The early symptoms are those of pleural effusion. There is cough with a shortness of breath, and there is the clinical feature of pleural effusion. But as the disease progresses, the pain and breathlessness become more severe, and there is increasing weight loss. And the physical signs are those of the large pleural effusion. The prognosis is very poor, with the rare survivor 2 years after diagnosis. We come to the last subject in our lecture, which is the chest wall disease. A disease affecting the chest wall, affecting the chest muscle, affecting the ribs, the sternum, and the spinal column. Could be congenital or acquired. Congenital, like those which affecting the sternum, called plexus deformities, like plexus carinatum or plexus excavatum, which result in the pigeon chest deformity or funnel-shaped chest, or disease which affecting the spinal column, like scoliosis or kyphosis, and lateral bending of the spinal cord, or posterior bending of the spinal cord, kyphosis, or this kyphoscoliosis, both of them. And the last one is the muscular dystrophy. There is disease of the muscle which affecting the chest muscle. The acquired could be either trauma to the chest, which result in the fracture of the rib, or like other diseases like ankylosing spondylitis or motor neuron disease, which affecting the chest muscle. And the pathological effect of the chest wall disease include: when the chest wall affected, chest wall by disease affecting the muscle, the rib, this result in the hypoventilation, and this hypoventilation result in the poor clearance of the secretion, and may result mainly to the atelectasis, recurrent infection, pneumonia, and patient may develop restrictive defect in the pulmonary function test also. So this is about my lecture, and I thanks for your attention. I hope that you are get benefit from my lecture. Thanks.